Next, I'll invite Dr. MINU MATHEN. Dr. MINU is a very prolific surgeon, has been teaching a lot of people, and he does all sorts of surgery. I've asked him to speak on SICS in small people because that again is a role. Thank you, Dr. MINU, for joining us.
Thank you, Dr. Suvan, and good morning, everyone. People who are leaving, I believe they don't do SICS in small pupil or they have other engagements outside, but then still, we all do SICS. And just now we saw one video from Deepak that when he converts, he wants a larger pupil and will use iris hooks. So I'll take it on from there, no financial interest. So in SICS, what is our basic problem? Especially when we have very hard nuclei, large nuclei, we need a larger rhexis and the whole nucleus needs. So I'm not talking about grade 1, grade 2, grade 3, which are okay with 5.5 rhexis. So beyond that, if we need to have larger rhexis and the whole nucleus has to come out into it. So if we do a relatively small rhexis in a case like this and do a hydrodissection and you see the pupil snap here. So if it is not adequately decompressed, you will find that the rhexis which is smaller will be easily obstructed by the nucleus which lifts up and the fluid will collect behind and it will give way. So a small rhexis is dangerous when you are doing an SICS with a larger nucleus and you are planning to forcefully hydrodissect and prolapse this kind of a nucleus. So we saw before, everybody showed stretch pupilloplasty. In phaco, after stretch pupilloplasty, if you don't apply hooks or rings, this will become too floppy and it will keep coming into your phaco port. But in SICS, it's not so. See, when a nucleus comes out through such a rigid pupil, it is anyway going to tear sphincters and it's anyway going to stretch. So it will be good to keep it stretched out with multiple sphincter tears which may happen in rigid pupils like this, but it won't work in elastic pupils or IFIS pupils where it will not stretch. So in such cases of rigid pupils, you have pseudoexfoliation, fibrosis and all those. Try this first, it will make it 1 or 2 millimeters more, and if it is good enough in your hands, you can proceed without a dilating device. Here again, it is around 5 millimeters. So if you want a 6.5 in this, we can do it hands-free without this one by going under the iris. So it's a blind procedure for anybody. Whoever says, however experienced we are, it is going to be a blind procedure underneath the iris. But the thing is, the movement of the needle, if you notice, 2 strokes away to the periphery and 2 strokes towards the center will maintain it under the iris without letting it escape into the periphery. So it should not come within the pupillary margin, but it should not run away also. So 2 strokes into the periphery and then 2 strokes back will let it remain under the iris and then retract the iris also along with your Sinski, along with the rhexis, so that you do not catch the rhexis margin when you are prolapsing. And the problem again can be because of the pupil being smaller and the nucleus being very large. The nucleus can get caught within the pupil. And here again, a stretch pupilloplasty would do well, and putting viscoelastic is very, very useful to push the iris around the nucleus by putting viscoelastics. And after that, this nuclei can be rotated out into the anterior chamber. But all these will take a lot of expertise, and actually these are not required if you have expanders which are freely available now. So my expander, one of them definitely goes underneath the main incision, the center. So this is where it goes. And you can notice that one is subincisional. So you lift up the anterior flap and see the lip, the posterior lip, and go posterior limbal and make a small stab incision. You can see that these are hooks from Grishaber, which are marketed by Alcon, and we don't have any financial interest in any of these. But these are actually really small and really malleable. You don't need to put a large opening for this. As Dr. Arup sir has told regarding the openings and all those, I don't want to repeat it, but then very small opening, less than the size of a 27 gauge needle, it can go through that. So assess your hook which you have and make only that kind of openings. Don't make very large openings for unnecessarily. And this one will retract the iris away from, otherwise if you put it on both sides of the incision, every manipulation is going to stretch the iris or pull on the iris. So after this, you get here we cannot restrain ourselves to a 5 mm opening because it has to be larger to get a 6.5. This is a 4 grade 5 nucleus. So and these kind of capsules are quite rigid ones. They are not then they don't stretch that much also. So we need to give an adequate capsular excess. I would give a 6.5 and up to a 7 mm excess in these kind of cases. So for that, this kind of a stretch is required, and as we saw, we should use capsular excess forceps. You can use high molecular weight viscoelastic to chamber to maintain the chamber. Always use the trypan blue to visualize it well. And once you have completed, the rexis has to be done under visualization. And once it is completed, now it's up to you. Hydrodissection or no hydrodissection, and prolapse it to Sinski, and the type of delivery according to what you're comfortable. The point here is the incisions which you have made should have been at the limbus, and it should have been vertical without going into the cornea, so that the iris doesn't get pulled up. So iris coming up crowds the anterior chamber and gives less space for the nucleus to come out. And if they are very much limbal, and if they are taken straight back in the same plane, you'll get adequate space even for this kind of a nucleus to be brought into the anterior chamber. Here I'm showing a prolapsing without removing any of the hooks, but later on you can release hooks. I'll show you those. And after aspirating the cortex only, we need to remove, or even after IOL implantation only, you need to remove the iris hooks. Here again, it is quite a large quite a large nucleus and a small. Again, I am repeating the incision, which is subincisional, which is very crucial. And after that, you can stain underneath the sodium hyaluronate or with air bubble and make a very large capsular excess because otherwise you're going to get a nucleus and bag delivery together. If you're making a very small rexus, it won't come out, or it will break the anterior capsule and you'll stretch to the periphery and it will wrap around and cause a posterior capsule rupture. So now I am releasing the subincisional one hook. So this will again, see, I am making sure that the internal incision is quite large, 1 millimeter more than the external, so that the nucleus will definitely easily come out rather than damaging the endothelium. And here, because the iris is down, it is easy to prolapse up the pole which is close to your incision. That is the point of releasing the iris hook there. Once that pole is out and if you rotate 180 degrees, that means the nucleus is very free. The rest of the nucleus which is in the bag, which is nasally, now I'm temporarily doing. So nasal part, it will easily come out when you put visco underneath the nucleus which is close to you. So with that, the nucleus can easily come out. You need not dial the whole thing out into the anterior chamber also. So this is the final one. This is a mature, hypermature one, though the nucleus is going to be smaller. So again, if you feel that the iris is crowding up, you can, after doing an adequate rexus, you can release 1, 2, or even 3 of the hooks once one pole is out. Get one pole out somewhere, get the iris hooks out. I won't take out all those because I will need to reapply this to identify the capsular margin and to take out cortex, because once you deliver the nucleus, pupil is going to come down again if you release all these, and then you will struggle to find out the cortex and you may leave cortex out. So visualization is very important in these kind of cases where you have chunks of cortex which may stick in the equator, and iris retractors have been released now, and after delivery that will be put back again and identify the cortex and take out. So in cases where you need to have visualization and to do an adequate rexus, please use iris retractor hooks to identify the periphery and do an adequate rexus to have a safe SICS. Thank you very much.
Thank you, Dr. MINU. Wonderfully covered entire SICS and really a large variety of cases. I'd invite you to join us over here, and we have about 7 minutes to take any questions. The panel will be happy to answer any questions. Any questions from the audience? Would the panel like to raise any questions, discuss anything? Deepak, you were talking about the color of the device. Yes, we've been struggling with that. The problem is made of polyimide, and polyimide, or the particular brand that we use, the global standard. We need a particular standard mechanical properties that comes only in that amber color.
Can you coat it with anything?
No, you can't.
Stain it with anything?
It'll start, if the coat starts peeling off during surgery, it's going to be very embarrassing for you.
That is true.
So we tried another.
I was also asking him about the color.
Yeah, not you, and lots of people, and I got a standard response on WhatsApp, which I forward. Actually, we tried a black color, but then the mechanical properties were not good. So that was in the prototyping stage, so I gave it up. So right now we are with this. Maybe going forward, we may try to work on that. Anything else, Dr. Prakash? Would you like to raise a question or make a comment about some other topics? About other topics, other things?
Things it's okay.
Yeah.
I spoke about IDS hooks, and there are a few points I thought I'll emphasize. Sometimes when it is a very deep set eye, very shallow orbit, and I mean very deep set. So in that situation, the IDS hooks may become a little messy. In that case, you can trim off the extended portion of the hook, so that the manipulations do not get affected. So that is one thing which I think I forgot to communicate during my presentation.
I think one message that I give to all my trainees and fellows is that many times when I ask, any of my fellow about a complication, what was your analysis? They start with the pupil became small and then, I had this complication. So I feel that small pupil should not be an excuse for a complication because we have so many now devices and iris. It's just many times the mind block of many beginner surgeons that they don't use any iris hooks or devices and just continue to do the surgery in the same way and land up with complications. So this is the line: small pupil should not be an excuse for a complication anymore.
Absolutely agree with you, Dr. Saurabh, because I always keep urging surgeons to lower your threshold for using a device. Have at least iris hooks on your tape. Because if you look at it, if you do have a complication, the time that you gained not using a device really goes down the drain. Because if you have a complication, it's another half an hour at least that's gone in that surgery, and the results are definitely contrary to your expectations. So you're in a mess. So you'd rather spend some time, a few minutes extra, and people who are proficient using iris hooks or pupil expanders, if you spend just about a minute more, and it I think brings a lot of safety, adds a lot of safety to the.
Yeah, because if you spend 1 minute more, that 1 minute anyway, you're going to spend more in phaco in a small pupil.
Exactly.
You're going to retract the iris, it will delay that. So always use that whenever you feel that that pupil is not good enough in my hands. That is my point. And the wrong notion of these rings or hooks cannot be used in topical patients. I've heard it from some people, that's why I'm making it clear. There is nothing like that. Even if you feel that if there is some pain or something, if you retract, just put intracameral lignocaine, which is easily available now, and that will clear off everything. So any stage topical phaco, rings or hook can be applied.
Yes.
I think MINU has put a very good point. That is something I forgot to emphasize. See, intraoperatively, when the pupil becomes small, if the patient has cooperated for topical anesthesia and you have selected that patient, subsequent manipulation do not make any difference, and you can definitely take up the patient. I mean, patient don't even realize the difference. It is the surgeon's safety factor, comfort factor.
We've actually grown up with the teaching that if you touch the iris, it becomes painful. Well, it doesn't. We've been using iris hooks in the topical anesthesia for many years. One tip for using iris hooks is when you use one of the hooks, use that as the lead for your next hook. Because once you've tented it up, you get the plane very easily. So go under that and then you bring it to that particular radial. So you use that. So every successive hook you can use that way, and that helps you. Sometimes if you have a tight situation where you're close to it's a shallow antechamber and you can't differentiate it between the iris plane and the capsular rim, it's a good idea to use a second instrument and tent up the iris over there, and then use the hook to engage. And once you engage one hook, you got that plane, you got a tented area, so you can do all the other hooks one after the other. So I think
one thing actually, in my clinical practice, if there is any history of using tamsulosin, and if I found that there is during irrigations, there is a drenching and flapping of the movement, I don't take any risks. I don't just want to foot the.
Yeah, absolutely. I think that we should lower our threshold because there's no reason. And if you look at it, I would always say, if you are the patient, you are undergoing cataract surgery, you have a 4 mm pupil, what do you want the surgeon to do? Use his heroic surgical skills or use a device? I think you have your answer.
So
And
basically,
still better if you think it's your mother-in-law going on the surgery.
no, I would definitely agree with Suven and Prakash. See, if the dilated PL ratio is less than 60%, and I mean, intuitively, initially you can titrate by real measurements with your intuition, and then it really works well most of the time. If it is less than 60%, I would definitely go ahead with iris hook.